Welcome back to the weekly Neurology Deep Dive. Just your friendly reminder that this is all for learning, no commercial interests here, and we're just hitting the high points of a research paper. As always, we really encourage everyone to check out the full paper for the complete picture.
Absolutely.
Today, we're taking a deep dive into what determines good outcomes after you've had postanoxic status epilepticus, after a cardiac arrest. And we're going to make this super practical for neurologists out there in the field, stuff you can actually use day to day.
Sounds good.
Awesome. So the paper we're looking at today is from Neurology 2025, Electrographic and Clinical Determinants of Good Outcome After Postanoxic Status Epilepticus by Admiral. And it's a sub-study of the TTM2 trial.
All right.
And the goal here, what we're really trying to figure out is, when you have a patient with postanoxic status epilepticus after they've had a cardiac arrest, how can you tell who has a better chance of having a good outcome down the road?
Yeah, that's the big question.
So we're talking about, 6 months out, a modified Rankin scale score of 0 to 3, and we're going to unpack this idea of a favorable PSE profile and how it can help you when you're at the bedside assessing these patients.
Makes sense.
So before we jump into the study itself, let's just set the stage. We know that postanoxic status epilepticus, or PSE, can happen in a good chunk of patients who are comatose after a cardiac arrest, like up to a third.
That's a lot.
It is. And, historically, this was pretty much a death sentence. But now we're seeing in about 10% of patients, they actually end up doing pretty well functionally. So the real dilemma is figuring out early on who's got a fighting chance and who we should be focusing our efforts on.
Absolutely. Got to triage those resources effectively.
Exactly. And that's where this study comes in. So tell us about the study design.
All right. So this is a prospective observational substudy of that big international TTM2 trial, which ran from 2017 to 2020 across 7 different sites in Europe. They looked at adults who were comatose, had been resuscitated from an out-of-hospital cardiac arrest, and were getting continuous EEG monitoring. Now, these CEGs were all reviewed at a central location, blinded, using the American Clinical Neurophysiology Society's standardized critical care terminology, the 2021 version. And then on day 4 after the arrest, they did the multimodal prognostication following the European guidelines.
Gotcha. So out of all the patients, how many actually ended up developing PSE?
So they had 191 patients who were on continuous EEG, and of those, 52 developed either possible or definite PSE. That's about 27%.
Okay, so more than 1 in 4.
Exactly. And this happened at a median of 42 hours after the cardiac arrest.
42 hours, that's almost 2 days.
Right. Now, the median age for this group was 70, with 35% being women. And keep in mind, they started that continuous EEG monitoring pretty early, a median of 8 hours after the arrest. And importantly, PSE was never present right at the start of monitoring.
Okay, good to know. So they weren't coming in already seizing.
Right. Now, just to be clear on what they were looking for, when we say definite PSE, we're talking about rhythmic or periodic epileptiform discharges faster than 2.5 hertz, or any kind of evolving pattern.
I see. And what about possible PSE?
For possible, it was things like periodic discharges or spike in wave at more than 1 hertz, or at least half a hertz if there was a plus modifier or fluctuation. They also included lateralized rhythmic delta above 1 hertz with a plus modifier or fluctuation.
Okay, so various levels of, organized epileptiform activity.
Exactly. So they had these different patterns, and now they wanted to see, okay, can we use this to tell us something about the patient's prognosis? And that's where the favorable PSE profile comes in.
Right. It sounds like this profile is kind of a step-by-step system.
You got it. So the first step focuses on when the PSE starts, within those first 3 days. To be considered step 1 favorable, 3 things have to be true when the PSE starts. It has to start more than 24 hours after the cardiac arrest. The EEG background activity has to have returned to something close to continuous normal voltage before the PSE starts. And there can't be any burst suppression with identical or highly epileptiform bursts before the PSE starts.
I'm seeing a pattern here. It seems like they're looking for signs that the brain is, I don't know, maybe less damaged, more resilient.
Yeah, that's a good way to think about it. Step 1 is about looking for PSE that develops in a brain that might be in a better state to recover.
Okay, that makes sense. So what about step 2?
All right, so step 2 is all about prognostication, but this time it's after that 96-hour mark. So to be step 2 favorable, the patient needs to show either signs that their consciousness is improving or they need to not have any of the classic bad signs.
Okay, so what do you mean by signs of improving consciousness?
So they use the FUR motor score for this. A score above 2 means the patient can follow commands or localize pain. So that's a good sign, obviously.
Makes sense. And then on the flip side, what are those bad signs that they're looking to avoid?
There are a bunch of them, actually. Let me run through them. First, if the pupils and corneal reflexes are bilaterally absent for 96 hours or more, that's a bad sign.
Yikes.
Yeah. Then there are the imaging findings. If the CT or MRI shows signs of global ischemic injury, things like generalized edema, reduced gray-white matter differentiation, sulcal effacement, or diffuse or bilateral multifocal ischemic lesions, that's another strike against them.
So basically, if the imaging shows widespread damage, that's not good.
Right. And then we have biomarkers. If the highest serum neuron-specific enolase, NSE, level is above 60 nanograms per milliliter, that's another point towards a bad outcome.
NSC, that's the brain damage marker, right?
Exactly. And if the N20 somatosensory evoked potentials are bilaterally absent for more than 48 hours, that's also a bad prognostic indicator.
Okay, so we've got bad reflexes, bad imaging, bad NSC, bad SFPs. What else?
Well, if the EEG itself shows a highly malignant background, like suppression or burst suppression, for more than 48 hours, that's also a bad sign. And lastly, if they have clinical status myoclonus early on, within the first 72 hours after the cardiac arrest, that's a bad sign regardless of what the EEG shows.
And by early status myoclonus, you mean it's continuous and generalized for at least 30 minutes.
That's right. So to sum it up, step 2 is about looking for either good signs, like improving consciousness, or the absence of any of these major red flags.
Got it. So if they meet both step 1 and step 2, then they have the favorable PSE profile.
Exactly. If they meet step 1 but not step 2, it's mixed. And if they don't even meet step 1, it's unfavorable. And they don't even bother with step 2 in that case.
Okay. So how did the patients in the study stack up based on these profiles?
Well, 20 of them, which is 38% of the PSE group, had that favorable profile. And out of those 20, 12 survived to the 6-month mark. Yeah, and even better, 8 of those 12, so that's 40%, had a good outcome, meaning an MRS of 0 to 3. And this is huge. It means having that favorable profile makes it 2.7 times more likely that they'll have a good outcome compared to all the patients with PSE. So the positive predictive value goes from 15% to 40%.
Wow, that's a pretty significant jump. So finding this profile really does refine our predictions. What about the patients who didn't have the favorable profile?
This is the really interesting part. Every single patient who didn't have a favorable profile, whether it was mixed or unfavorable, they all had bad outcomes at 6 months. Either an MRS of 4 to 6, or they died.
So no one without the favorable profile made it out with a good outcome.
Nope, not a single one. That means the negative predictive value for not having the favorable profile was 100% in this study. It's a pretty powerful indicator.
It certainly sounds like it. Did they notice any other trends in the data, like clinically?
Yeah, they found some interesting things. All the patients who ended up having a good outcome, they were all following commands within the first 7 days.
So if they're not showing signs of improvement by day 7, that's a bad sign.
Seems that way, yeah. They also found that clinical seizures were super common within the first 72 hours, happening in 77% of patients. And a lot of times, these seizures actually started before they saw PSE on the EEG.
Really? So the clinical seizures were showing up before the electrographic seizures?
Yeah, in 25 out of 35 patients where they had the data. And these early clinical seizures were way more common in the unfavorable PSE group. Almost everyone in that group had them, 96%.
Wow. That makes sense, I guess, if the brains are already more severely injured.
Makes sense. Now, that early status myoclonus, the really bad sign, they saw that in 3 patients, and all 3 had the unfavorable PSE profile. And they also looked at the NSE levels. The median NSE level was much lower in the favorable profile group, around 27 to 28 micrograms per liter. But in the mixed and unfavorable groups, it was way higher, 74 and 94 micrograms per liter, respectively.
So the worse the profile, the higher the NSE, the more brain damage. What about long-term outcomes? What did they find?
Well, most of the survivors, unfortunately, had some level of cognitive impairment when they tested them at 6 months. They used the MoCA and SDMT for that. And most of them also reported a lower quality of life because of their health issues.
That's tough. But at least they survived, right?
Right. And you know what's really interesting? Even some of the folks with worse functional outcomes, they said their overall life satisfaction was about the same as the general population.
That's really surprising and kind of heartwarming, actually.
It is. And when they followed up at 24 months, all 12 of the initial survivors were still alive, and 7 of them still had a good functional outcome.
That's pretty good news, considering everything.
Yeah, it is. So what can we take away from all of this for our daily practice?
Well, it seems like this favorable PSE profile can be really helpful for figuring out which patients have a better chance of a good outcome.
Absolutely. And on the flip side, if you're seeing an unfavorable PSD profile early on, especially right after the cardiac arrest, that's a strong sign that the prognosis is poor.
So we should probably be having those tough conversations with the families earlier rather than later, helping them manage their expectations.
Exactly. Of course, any decisions about withdrawing life support have to follow the established guidelines and be done later on, but having this information early can be invaluable for those conversations.
Definitely. And it sounds like clinically, if a patient isn't showing any signs of improvement by day 7, that's a bad sign.
Yeah, that seems to be the case. Another takeaway is that continuous EEG monitoring is absolutely essential. We have to catch those evolving EEG patterns and pinpoint when that PSE is starting. And it's not enough to just look at the EEG in isolation. We have to integrate those findings with the clinical picture, things like those reflexes, the biomarkers, and the other prognostic indicators we talked about.
Right. It's all about putting the pieces together.
It is. Now, there are a few things to keep in mind. More research is definitely needed to see if these findings hold true in other groups of patients.
Yeah, replication is key.
Absolutely.
Yeah.
And we also need to figure out what role anti-seizure medications play in these different PSE profiles. They noticed that generalized periodic discharges with that classic triphasic morphology were more common in the favorable profile group. But the ones without that triphasic look were often in the unfavorable group.
Interesting. So there might be subtle differences in the EEG patterns that we need to pay attention to.
For sure. And one last thing to think about is that sometimes when you discontinue propofol, it can affect those rhythmic and periodic patterns on the EEG, especially in patients who have a continuous background.
So we have to be careful about interpreting those findings, make sure they're not just an artifact of the medication changes.
Right, exactly.
Well, this has been a fascinating deep dive. It really highlights how important both the electrical activity in the brain and the clinical signs are for predicting how patients will do after they've had postanoxic status epilepticus.
Definitely. And this idea of a favorable PSE profile, with its late onset from a continuous background and the absence of all those red flags, seems really promising for identifying the patients who have a much better chance of recovering well.
Totally. So for our neurologist listeners out there, this framework gives you some concrete criteria to use when you're assessing those comatose patients after cardiac arrest with PSE.
Absolutely. Continuous EEG monitoring is crucial, and you got to put those EEG findings together with everything else you're seeing clinically and all the other prognostic markers. That's how you make informed decisions and have those crucial conversations with families.
Couldn't have said it better myself. And just a reminder, this is just a summary. We highly encourage everyone to read the full paper by Admiral and the team. It's in Neurology 2025.
Definitely worth a read.
So think about how these findings might change your approach to managing postanoxic status epilepticus. What other questions does this raise for you? Until next time, keep diving deep.
See you then.